What orthopedic diseases have genetic origins?
It's actually a very broad question, so let me try and narrow it down for the purposes of making it easy for a lot of people to understand what we're up to today. So, for starters, it is believed that in the modern context of things, after the human genome has been discovered and its various nuances have been understood to some extent at least, that a whole lot of diseases do have a genetic basis from which they manifest depending on various interactions that we have with our environment and various other predilections and causes that may occur over a period of time. And it is definitely true that certain genetically predisposed conditions may not eventually show themselves up because of certain other genetic changes that we may have in our bodies. Keeping that concept in the background, the sort of genomic background of disease progression in the background, it's important for us to understand that certain diseases or disorders need not always be diseases in themselves. So, for example, if we look at osteoarthritis, the sort of age-related wear and tear changes that occurs in practically all of us, that to some extent is genetically predetermined, agreed. But then again, it's to a large extent driven by how we use our bodies. So people who, let us say, do a lot of physical exertion and spend a lot of time on their knees may wear out their knees earlier compared to somebody else who lifts a lot of weight and injures their back repetitively. They may have more and more wear and tear changes in the back. Now, these are another scope of discussion.
What are the factors involved in diagnosing osteogenesis imperfecta?
There may be a purely orthopedic manifestation of a genetic disorder, such as, let us say, osteogenesis imperfecta or so called brittle bone disease, where the bones themselves tend to have very easy fractures. So, even with most trivial injuries, the bone tends to break. By and large, this problem is more common in childhood, and the affected child, as the child grows up, tends to become less and less susceptible to having fractures. And typically, by the time they're adolescent and adults, that tendency generally peters off, and they tend to become more stable and less likely to have fractures. So, this is one example of an essentially orthopedic genetically determined problem. But there are orthopedic coincidences. So, for example, if you take a whole lot of hematological problems like thalassemia, they have orthopedic manifestations simply because their problem, which occurs in the bone marrow, renders the bone slightly more easy to break because of the higher turnover that's going on in the bone marrow. They have a greater tendency for the bone to become softer and a tendency to break very easily. And of course, because let us say in thalassemia, there is a large deposition of iron in the bone, it tends to slow down the way the bone remodels itself, heal itself, and that interferes with the way the bone behaves over a period of time. So, this in a nutshell should uh, help us understand that dealing with bone related problems in the sort of sphere of genetically predetermined diseases need not always be purely orthopedic issues. It may be orthopedic coincidental issues as well. Specifically of osteogenesis imperfecta. Osteogenesis imperfecta has got multiple types, of which the most common variety follows this pattern. The most uncommon variety, thankfully, is unfortunately more or less lethal in the sense it does eventually result in a very early end to life of the child. So that variety, thankfully, is very, very rare and uncommon. The more common variety uh, is the variety where the child has fractures with, as a toddler or even as an infant, the child rolls over, has a small trivial fall, sustains a fracture, is brought to the family physician or the pediatrician. They recognize that the child has a fracture. The fracture is treated, maybe with an orthopedic surgeon. And then again, the child has yet another fall for probably no significant reason. The bone breaks. So when this sort of a history crops up, the pediatrician or the family physician or the orthopedic surgeon involved definitely start looking at the concept of osteogenesis imperfecta.
What precautions must parents of children diagnosed with osteogenesis imperfecta take?
Once that diagnosis is made, uh, definitely there is probably a need for some amount of counseling to the family to be careful, to try and keep the child safe from preventable falls, uh, decrease the appetite for risk as far as the child goes. So, for example, if the child is encouraged to participate in contact sports, then the risk of an injury is far higher. That way, by mitigating the risk that the child is exposed to, the risk of the fracture itself can be brought down. So, this is one aspect of management which is not generally speaking a sort of a medical management, but is basically something which is involving the family, involving caregivers, where the appetite for risk can be modified and the risk of the injury itself can be toned down. So, this is one aspect of things. Now, as I said, this most common variety of osteogenesis imperfecta, as the child grows older and older, the tendency for the fractures tends to come down. Okay, this is not a general sort of rule that's applicable to everybody, but it tends to happen that way. And by the time they are young adults, that tendency drops down to the point where they can participate in most routine activities that young adults can do. So, may not be contact sports, but definitely they can participate in regular physical activity, attend a job, get to college, participate in sports or activities that are fairly compatible with their uh, health status. So they can get back to more or less normal activities over a period of time. That is a that when that happens, I think that's a great success story for that individual, for that child who's now a young adult, and for the family, and for everybody around that particular child who has facilitated this process to fruition.
Can children with osteogenesis imperfecta be taught to anticipate falls?
Does the child have a sort of premonition that this fracture is going to happen? Not really, because you see, the bone is basically there, and unfortunately, it is very easy to break. So you have to look at it as the bone is kind of weak or brittle, if you would so call it. It doesn't have any real problem with healing, and the bone doesn't have any real problem with um, getting back to some degree of strength once the injury has happened. But unfortunately, the bone inherently is not strong enough to tolerate the routine loads that childhood would throw at the bone structure. So that's the problem. You see, all of us as children have played around, have jumped off parapet walls and trees and bushes that we decided to climb, and done all that mischief. And our bones don't break yet. For these children who have, let us say, osteogenesis imperfecta, their bones won't tolerate that sort of loading, and they have a tendency to break with what would be considered as stresses and loads within the normal range. Okay. Now, what I mean is that if somebody falls off the first floor, I don't think we should call that a range of normal loading, isn't it? But if somebody jumps off, let us say, a child jumps off a kitchen platform, which is, let us say, 2.5, 3 feet high, that would be part of the picture of normal activity that most children would do and get away unscathed. So, when a child incurs a fall from those sort of activities that are perceived to be more or less normal for that age group and activity level, that creates a need for being sensitized towards the problem. Now, to the first part of the question, which is uh, at sort of what age do these things crop up, and what are the sort of example situations where, let's say, osteogenesis imperfecta manifests itself? This can occur in very early childhood. So, for example, child falls off a bed and sustains a fracture involving the thigh bone, or a child uh, is carried by parent, and after that the child has multiple tiny cracks in the ribs. So these sort of injuries definitely need to be a sort of alarm bell in the mind of the team that sees this child later on.
Getting family history is essential to understanding osteogenesis imperfecta.
I have to add a very important point here, that uh, both in India as well as in most Western countries, this problem where children wind up with fractures on a repetitive basis, and with what, see, I mean, at the end of the day, the child cannot tell you that the child actually fell down, especially a small tiny child who's about a year or year and a half of age. It's about what the parents tell us. So the question is that should our antennae be extended and looking out for potential child abuse when a child keeps coming back with repetitive fractures? In this day and age, I think that's a very valid question, and I think it is absolutely important that our antennae are up for this particular very difficult to pick up and solve problem. But we should not believe that we are hunting for child abuse, whereas in reality, the child actually has a problem, in this case, osteogenesis imperfecta. At the same time, one should not miss, sorry, one should
Exactly.
not miss a potential child abuse situation either. So
Right.
this is where, it's about having multiple people see the child, pediatrician, let's say a family physician, the orthopedic surgeon, somebody who knows what's going on in the family dynamics of the family. So maybe neighbor, elder person in the neighborhood, these sort of, this is where it's very important in a country like India, where there is still the concept of neighborhood family doctor in most social environments, who know the family for generations. They know this child, they know the three generations up, and they know cousins this way and that way, so they know the whole story, and they're in a position to tell you, you know what, this is not really that sort of a problem. This is definitely, the child is getting fractures because that family doesn't have this issue, or the other way around, the family has had his history of some domestic violence, some sort of repetitive argumentativeness between members of the family, and that may be reflected upon the child. So it's very important that we get our antennae up. We don't dismiss the issue of potential child abuse, and yet that should not be the top focus and priority. We treat the child every single time on its merits, and at the back of our mind, this question of, is this potential child abuse, has to be looked at and addressed. And basically, I believe that it is not feasible for one individual person to take a call on this, especially because we don't live in that household.
Tracing the genetic roots of osteogenesis imperfecta.
I think it's very important to understand that there is some manifestation of this condition most often in either parent, both parents, or maybe even occasionally a couple of generations higher up, especially if both parents happen to be carriers. Now, having said that, not everybody remembers their childhood. So it's always a good idea to uh, keep this on a repetitive questionnaire kind of thing, where uh, when the child comes back with repetitive fractures or more than one fractures, or when we see on the x-rays that there is one fracture that's happened today and there is another fracture which has healed recently, which we can see on the x-rays, then generally speaking, this question starts coming up. Anybody in your family who's had this sort of problem in the past? uh, have you heard of this problem called osteogenesis imperfecta? Did anybody in your family have this tendency to break bones, very easily? Was anybody treated for this? I think these are history-based questions which are, at least in today's world, still valid. I'm sure in a few years down the road, I'm sure there'll be a blood test that will come about where or maybe you never know, maybe it's just a swab from the mouth, where we look at the genes and then we say, okay, you know what, this child has got osteogenesis imperfecta.
Osteogenesis imperfecta is characterized by low energy injuries.
What we need to understand is that most often these injuries are low energy injuries. That means to say they occur with trivial levels of injury. So they tend to be so-called clean breaks or easy to realign kind of situation. They are not shattered, if that being the other kind of extreme situation. Uh, so yeah, they tend to be probably a little easier to treat. The tendency is to try and treat them without surgery wherever it's feasible, and to try and sort it out as much as possible with less disturbance to the child, especially if the child is in school.
Why genetic counselors are essential in managing osteogenesis imperfecta.
Yeah, I think very importantly, at least in our practice, we have a reference out to a genetic counselor, because that's very important, that the family understands what it is that they're dealing with. See, I mean, some of the questions may be very pertinent. This may be the first child. And then the pertinent question would be, what is the risk to my next child? We're planning to have another child. What is the risk to that child? It's a very pertinent question. I think it's far wiser to invite expert opinion from genetic counselors who have a lot more information at their disposal to guide parents with this extremely important decision making process. And obviously, at that point in time, the appropriate tests, the sort of detailed history taking, a sort of family tree evaluation, seeing what is it that is going on here. Does this child have a sort of de novo or spontaneous mutation, or is this something which is already historically present in their family, which is manifested now in this child? Uh, you know, those sort of questions will need to be evaluated and then answered. That is, I think, the first important step. The next is counseling with regards to the care of this child. And that is where it's important to again have a sort of multidisciplinary approach. There are pediatricians involved, there are orthopedic surgeons involved, and sometimes even we take the help of the family physicians, because sometimes their pediatrician is very far away from their house and they'd rather just relate with the family physician who stays close by. So it's always a sort of multidisciplinary team effort to try and get better and better care for this child. Depending on the severity of involvement of the child, sometimes there is a need for hospital stays for the child during a fracture, surgical care. And when that happens repetitively, I'm sure the cost starts escalating. At that point in time, I think it's important to have some sort of social help available for the child. Does this particular child have osteogenesis imperfecta? That is a question being asked. I'm sure the genetic probe test that will give us the answer to that is probably around the corner. You see, the headache with these sort of tests is uh, you see, everything will have a pro and a con. So that definitely holds good with tests as well. So the question is, should it be used for screening uh, all offspring of this particular couple who had this child with osteogenesis imperfecta? I think that would be the next question. So you see, the use of that test will gradually broaden over a period of time.
Osteogenesis imperfecta. Treat the fractures. Observe the frequency.
The first item on the agenda is, let's help this child who's got severe pain because a child has a fracture. So whether the child is a 10-month-old child or a 10-year-old child, the pain is pain and it is severe. So that needs to be treated. So the fracture gets treated on its merits. That's the first thing that we all must remember. Then comes the other questions that we asked in between. Is this the first question or the nth fracture? What are the other fractures? Is there any deformity that is there? Is that something that has to be corrected? Can we use this um, fracture situation now as an opportunity to correct any pre-existing deformities? Can we do something today to prevent a deformity occurring tomorrow? So these are questions that are asked as a next step. Then comes the other question of the sort of what I told you, your antennae are up and you're kind of looking around for other potential causes for a child who's coming back repetitively with injuries. That is something, and that has to be handled outside of uh, dealing with the child's fracture itself. Now, as the fracture starts healing, let us say we treat it with a plaster and then the fracture starts healing, obviously there is a period of care that is required to make sure that the fracture heals in the position that we've kept it, in the safe position. And that involves counseling the parents, taking care of various requirements for the child. So, for example, if the child has an upper limb fracture, then it is relatively easy to manage the child because the child is still able to sit, stand, walk, and move around depending on the age. Now, if the child has a lower limb fracture, let us say a fracture of the thigh bone, then it becomes so much more challenging for the caregivers of the household. So, there is a lot of effort spent there to help them figure out what is the best way to deal with the child with this injury. How do we uh, take care of the child at home? How do we prevent complications with the child being on some degree of bed rest? So, all of these issues are dealt with in the initial few weeks as the fracture starts healing, with monitoring with x rays from time to time to make sure that the position is all right. If surgery is done to deal with the fracture and to keep it well aligned, and that is required, when then so be it. And then sometimes we have to hold the fracture in place with devices or implants to hold the fracture in place so that the bone kind of maintains itself in good alignment while it heals. Then, as the appropriate time, exercises for the involved region, exercises for the foot and ankle or knee or the hip joint, or in the upper limb, fingers and hands, so that the child gets back better function. At the end of the whole process of healing, let us say 2 months or 3 months, we want the child to get back to as good function as the child had before the fall. That's a very important thing that we would like the child to achieve.
Treatments for osteogenesis imperfecta.
Now, in the meantime, with osteogenesis imperfecta, we let us say we've picked this problem up for the first time. Then there are the questions of what do we need to do to help the bone quality become better. So there are certain medications that are used. At this point in time, those medications are injectable. So the child is given a brief course of those injections, initially every 3 months, and then it becomes every 6 months to help maintain the strength of the bone. Okay, so that goes on for some time, and typically this process uh, goes on with those injections occurring every 6 months, and eventually, as the child becomes older and a teenager, once a year, till the child reaches adulthood, and then the tendency for fracture gradually diminishes and comes down. And in the meantime, we always encourage children with this problem to stay as physically active in a safe manner as is possible. So, what do I mean by that? I already mentioned that it would be a bad idea for them to get involved in contact sports. Fine. But that doesn't mean that they should not participate in sports, isn't it? They can definitely participate in certain sports that will have a lower risk of injury to them, a lower risk of fall, a lower risk of sustaining fractures. So we sit down with every child. I mean, you can't have a sort of one idea suits all kind of situation and say all children with this problem shall go play badminton. That doesn't work. So we have to find out with the child what the child is interested in and figure out or try and channelize the child to opt for sport activity to maintain health, to maintain fitness, to maintain their mobility, and the myriad positive aspects of sport uh, must be emphasized to the parents and the child, and to overcome their innate fear of sending the child out to play, and gradually get the child involved in more and more physical activity, because bone is a very interesting living part of our body, where when it is exposed to a higher level of physical loading and stress, it actually strengthens itself. That is the magic of bone, and that is very, very important. So we harness that in this in this aspect of treatment, where we encourage children to be more physically active, with the caveat that they have to uh, play safe, shall we say, covering
Absolutely.
acute care, a sort of intermediate care, and a sort of long term spectrum that we should be looking at over a period of time.
The problem of patient access in osteogenesis imperfecta.
Yeah, I mean, at least in this sort of setup where I work, I mean, considering that I work in a large city, Bangalore, uh, and I'm sure in your city in Chennai as well, there are facilities for people to seek advice on genetic counseling, and I think that's the best way to go about it. Now, when we do have patients who are coming in from uh, outlying areas, sort of more outback areas, that doesn't mean that they are not in a position to reach these facilities. So, see, at the end of the day, when people come from an outlying area to a large city for medical care, they understand very well that their medical care in their cities or towns are limited, and that's why they're coming to the larger city for help. So it's only fair that we try and guide them to the best options available to them for their set of problems. So over a period of time, each one of us would have either worked with a team or would have built bridges with a team that focuses on specific aspects of genetic counseling. So obviously now, for example, if somebody has, let us say, hematological problem with an orthopedic manifestation, then I would get my team in hematology involved, as well as a genetic counselor team involved. And the way it works, at least in our group where I work, is that if I refer this child to the hematologist, they automatically send the child to the genetic counselor with notes from their side as well. So when the child and family reaches a genetic counselor, they've got notings from my side as well as from the hematology side. And so the genetic counselor has so much more information to work with and supposed to deal with as well, that they can make far better calls to help the patient and their family to take decisions in future.
The crucial role of support groups in managing osteogenesis imperfecta.
In today's world, I think I have to look at it as it's a collective effort, where in the support group, there's a lot of ability to exchange ideas, experiences, a lot of opportunity for people to share what has worked for them and what doesn't work for them. Okay, what may work in the first patient's household need not always work in everybody's household. So that issue, I think, is there, and that's up for discussion in these sort of support groups. And nowadays, with the advent of online fora, where it's no longer sort of physical meeting that happens in a particular hall or some particular person's house every so many days, this online thing has really changed the way that support groups work. The dynamics have changed. The ability to share contacts, videos. This is what's happening with our child. We use this particular uh, system to help our child to, improve the condition. Now, parallelly, we have to understand that there are changes occurring in our society where there is a greater awareness for children who have different needs from the average. So the ability to cater to the various ends of the spectrum has actually increased in our society by and large. And I think you'll have to agree with me on that, that in, let's not even discuss large cities, but even tier 2 cities, and sometimes even you'll be surprised at how in tier 3 cities there are numerous schools that are being set up to help people with abilities which are limited in the conventional sense, with an ability to focus on certain aspects of their development which are going to render them independent over a period of time. That is an amazing change that I think in the past 20, 30 years maybe that we witnessed in our society in India. And I think we have to be really grateful for the people who have set up these projects and people who have overseen them and brought them to fruition.
Building social empathy for osteogenesis imperfecta.
What I'm referring to is the tendency for children to get bullied in school because of perceived difference. So this may have to do with, let us say, since we're using osteogenesis imperfecta as an example, let us say the child winds up with a deformity in the foot or the leg because of repetitive fractures that have happened. The tendency for the child to get picked upon by his or her peers is very high, and that is true in India. It is true in any other country as well. So the sensitization then in schools to try and pick up on this sort of bullying or victimization.
The long-term costs of managing osteogenesis imperfecta.
Yeah, so I think there are various ways to look at cost. And I'm presuming at this point in time, you're discussing the sort of monetary cost involved with treatment and care of a child with these sort of problems. I'm presuming that's the topic of discussion. There are other costs that are kind of hidden and which actually translate into monetary cost, and that may actually need to be looked at. So things like how do you organize for a child with a disability to climb stairs? It's not possible for certain children to do that. So then the parents have to hunt for a house that is on a ground floor. That's more expensive to stay in, or they have to opt for an apartment with a lift, which is also more expensive than a house on the second floor with a narrow stairway. So you see, there are costs which are related to the treatment of the child with the problem, which are not directly linked to uh, care of the child. I hope you understand that that is a sort of secondary uh, cost that is involved, which is monetary as well. The non-monetary cost is a separate discussion altogether. Now, when we discuss the monetary cost of treatment for these sort of problems, uh, I'll put it to you this way: when the child comes with the first fracture, everybody is enthusiastic to, you know, sort out the bills and take the highest possible room that's available and whatever else. When the second fracture happens, people have a frown on their face, and then they still kind of figure out some ways to pay it, whatever else. By the time the fourth and the fifth fracture starts happening, I think that's when people run out of steam in terms of their ability to pay for the cost of care, the hospitalizations, and such things. This is where a sort of social safety net is required for people with um, these sort of uh, problems that may incur recurring hospital uh, costs. The government has made many attempts at taking care of this. And I think they did do something with regards to whether the insurer is going to object to these sort of so called genetically predetermined conditions or not. And I think that has been legislated, but then on the ground, I'm not too sure whether it's actually happened. Uh, I'm sure you will have more details on that. So you can fill me up on this, definitely. Uh, so, what is the present status on the government and the insurer and covering for uh, genetically predetermined diseases? Because the moment that we use the word congenital in an insurance form, we all know what happens to that. Those are actually not very expensive. See, the
Okay.
problem is not with uh, the expense of those injections. The one problem that we tend to face from time to time is availability of those medicines, because uh, those medicines are not very easily available for use in children. So getting them sourced, getting a pharmacy to disperse it in a hospital, and then to use it for the child with the pediatrician's guidance, all of that needs a little bit of effort and maybe some time. But then at the end of it all, it's not very expensive when you are looking at the ability of this small tiny injection and its ability to prevent another fracture. I think the cost literally pales into insignificance, and patients and their caregivers definitely understand that. I don't think that's a major problem. The major problem is with children requiring repeated hospitalizations for their fractures and injuries and treatment of their medical or orthopedic problems, where bills can be quite high nowadays. That can be very scary for them.
The ethical considerations of expanding testing for osteogenesis imperfecta.
The uh, the sort of genetic counselor team, and sometimes other specialists who are also involved in giving care to the child or the family with this genetic condition. Let us take, for example, a child with osteogenesis imperfecta. Let us, for argument's sake, say that the father of this child has got three other siblings. That is, this child has got three or four uncles and aunts, each of whom are planning to start their own families. Now, between you, me, and the flagpole, there is no debate that one should involve them in this discussion, isn't it? But uh, the ethical question arises that do these individuals who are adults by themselves and their respective families, are they wanting to be part of this discussion? Do they want to be involved with this knowledge that this potential, let me emphasize that word, potential genetic trait or disorder can affect their offspring? You see, that's a question that is the ethical question that's being asked at multiple fora, and I don't think there is a valid answer for that as of now. So as of now, what we are doing in our care situations is that we talk to the families and we figure out from them if they are interested in pursuing this, and if they are, then we definitely get them to meet the genetic counselor team, and they have the wherewithal to advise them uh, with a certain degree of care and a certain degree of being cautious about you know how much of safe information to give them, that this is the best way forward for them to take decisions henceforth. uh, See, the ethical debate has run on in various fora on reproductive rights and such things. uh, I'm not particularly sure that uh, uh, we have a real answer to this as of now.